Go live.
Okay, perfect. Hi, everyone. Welcome back to our Monty Heart Cardiology lecture series. It's a great pleasure today to introduce a colleague and friend, Vikram Brahmanandam, who will be talking about cardiac MRI and ischemic heart disease, a very hot topic right now. So Vic he did his cardiology fellowship at University of Illinois in Chicago. And then he trained in cardiac CT and MRI in a very busy and great training center at Ohio State University. He is an assistant professor of medicine at our School of Medicine, Albert Einstein College of Medicine, and he is a multimodality imager. He reads a lot of echoes like we all do, CTs and MRIs, and he also does clinical cardiology. So thank you very much for being with us, Vic, and looking forward to the lecture.
Great, thanks so much, Leandro. Appreciate it. It's really a pleasure to be part of this lecture series. We've had really excellent talks, so I'm really happy you sort of arranged all of this. It's been a great addition to Montefiore. So I want to talk a bit about cardiac MRI and ischemic heart disease. And I really want to focus in on stress MRI because it's something that, especially in the United States, is pretty underutilized. And I think with the whole debate between anatomic assessment and functional assessment, I think it's a good time to just take a look at stress MRI and where it might help us. I don't have any disclosures. And just as a quick review, in terms of MRI in general, outside of just stress testing, we're able to get quite a bit of information. It's really the gold standard for assessing ventricular function, and I would also say the gold standard for viability assessment. But other things we can look at, especially in ACS patients, and I used to do a lot of this in training, you can really look at things like area at risk with T2 weighted edema imaging. You can look at microvascular obstruction with first pass imaging, even intramyocardial hemorrhage with T2 star imaging. And all of these all of these tools help you to risk stratify patients and prognosticate a little bit better. Also, compared to echo, even contrast echo, thrombus assessment is a lot better with MRI, and we really don't miss smaller thrombi that you might with contrast echo. And there's added value in terms of looking at the valves. So with the ischemic MR, we do a really good job quantifying the severity of MR. We can look at the mechanism very well. We can see all of the leaflets, all of the scallops, and figure out where the issues are. It's easy to see tethering and to see why there might be tethering of the posterior leaflet, for example. We can look at infarct size and how that interplays with prognosis. And additionally, in MINOCA, so myocardial infarction with non-obstructed coronary arteries, I think MRI is really the leading modality to help elucidate what the etiology might be. So even before getting to stress, there's really a lot of added value with a cardiac MRI in anyone with coronary disease. And the information that I'm talking about here, in a center that does a lot, you can really get most of this information in 30 minutes or even under 30 minutes in some cases. But for today, I want to focus in on stress myocardial perfusion imaging. I want to look over some of the newer data that's come out over the last couple of years, and especially comparison with FFR, and also just to consider if a multimodality approach might be the future of a coronary disease. So there's an interesting study that I'll talk about where they looked at using coronary calcium scoring as a gatekeeper to functional testing, and then using stress MRI in that setting. And then I'd like to talk about some exciting non-contrast stress MRI techniques that are coming up. So before I get into MRI, I think it's worth just revisiting coronary CTA. I read both, and I see the utility of both. In patients with stable coronary disease, with low to intermediate risk for obstructive disease, I think there's an excellent case to be made for a CT first strategy. And I think most cardiologists at this point are agreement on that. It has excellent negative predictive value and the ability to identify non-obstructive disease where functional testing might not pick that up. Really gives us the opportunity to treat patients earlier with statins, aspirin, or other sort of risk modification measures. So looking at the left side of the screen, we have the Scott Hart trial. This is the 5-year follow-up study, and I think this is really the game changer, and it's really affecting how we practice cardiology. So really in the CT arm, there was a reduction in death and non-fatal MI with a CT sort of strategy compared to standard care. And looking at the right side, this is a large Danish registry that compared, and this is actually quite a few studies. So there are 53,000 stress tests or functional studies and 33,000 CTs. And what you can see is there's a significant difference in terms of patients getting started on a statin and an aspirin. And at the same token, patients were also taken off of aspirin if it wasn't appropriate. So with coronary CT, you're really able to improve medical management and identify patients early. I didn't include the PROMISE trial on this slide, but one thing to note from that trial, even though it was a negative trial, about 2/3, I think, of the patients who had cardiac events in PROMISE ended up having normal functional tests, but they did have non-obstructive disease by anatomic assessment. So again, functional testing can miss patients who have non-obstructive disease, and it's important to catch them. And we're seeing with the UK NICE guidelines, and then the NHS is now adopting FFRCT to add a functional portion to the CT exam. And even large payers in the United States are now catching on. So Cigna and United have really pushed for a CT strategy first as well. And in my own practice, I just wanted to share, this is a patient I saw last week while I was on the inpatient service. It's a 37-year-old female and really just poorly controlled hypertension. She hadn't been in to see her doctor due to COVID. And so she came in, her blood pressure was in the 220s. EKG was normal, minimal troponin leak, but she had chest pain that sounded somewhat typical. And we opted to do a CT in this setting because we weren't convinced it was ACS. And if you look closely, this is just an axial view. I didn't even get to the reconstructions. Just flipping through, you can see that there's this soft plaque causing kind of like a mild to moderate obstruction in the LAD. And there's really no calcium surrounding it. It's purely just soft plaque. And then she did go on to CAP because she had some ongoing symptoms. And you can see there's this non-obstructive lesion here. So the beauty of CT is you really can see this sort of mild soft plaque. You really can't pick this up with any other modality. And what I think is, what's more important too is this is a massive Swedish study. It's called the cardiopulmonary bioimage study. They presented their initial data at AHA last year, and what they were trying to do is to create an AI algorithm looking at multiple different risk factors to create a clinical model to predict who might have widespread coronary disease. And they were able to identify about 2/3 of patients. Everyone underwent CT angiography. But what's striking is in this asymptomatic pool of middle-aged patients, 42.1% were found to have some degree of coronary disease. And even in asymptomatic folks, we were able to find 5.2% had severe disease as defined by obstructions greater than 50%. So I'm not advocating that we do contrast CT in everybody, but it is important that we really work harder to identify patients who do have coronary disease and treat them earlier. And whether we can get away with just doing a calcium score is also something to think about, and how to marry that with functional testing. And then, so kind of last slide before we get into MRI, I just wanted to talk about the ischemia trial as well, because this created a lot of controversy regarding functional testing. And, I think a lot of people were joking about, people who read functional testing, they're going to be out of a job. But if we look into it a little more, ischemia trial looked at stable coronary disease, patients with moderate to severe ischemia, and they also had to have no significant left main disease by CT. So randomizing these patients to initial invasive versus medical therapy, there really wasn't a benefit seen with the invasive strategy. However, there's quite a few patients were excluded from the trial. So anyone a bit sicker, so people with reduced LV function, worsening heart failure, unacceptable angina, recent ACS, or any kind of revascularization within a year. Basically, patients we see in clinic every day. This trial doesn't really apply to them, and we still need to have a way to look at these patients and to identify whether they may or may not benefit from revascularization if they have persistent symptoms. Other things to note about ischemia trial, 50% of the functional testing was SPECT, and we know SPECT has some issues. 20% was echo, and more striking is 25% was EKG alone. And EKG alone stress testing was pretty poor sensitivity and specificity for obstructive disease. And then 5% was CMR. And I think this reflects what goes on in the United States today. And of note, the EKG stress group alone, that defined 50% of those with severe ischemia. So again, I think these are just important things to think about when we want to talk about what's the utility of functional testing and where might we use it. The trial wasn't designed to evaluate different stress modalities, and it wasn't designed to compare anatomic versus functional testing. But it certainly does suggest that a CT first strategy might work because we could rule out high-risk disease and patients with moderate to severe ischemia can safely be managed that way. So I think focusing in more, I think we have to look at these sorts of patients. So those with known disease, those that are sicker with LV dysfunction, there is evidence that functional testing and guiding revascularization by functional testing is useful, even back to the FAME trial, for example. So I think these are some of the reasons that I would say stress MRI in particular is going to have a heavy role in the future management of patients. In general, functional testing is useful for assessing symptoms, especially if you don't have typical chest pain. If you just have a patient coming in with poor functional tolerance or dyspnea, it's an excellent test to guide and assess the effectiveness of medical therapy, prognostic value, assessment of microvascular dysfunction. And I find it very useful as well for just discussing with patients who are going for revascularization, whether or not we think it'll be helpful. Stress CMR in particular, too, the diagnostic accuracy is excellent, and it's cost effective in the USA, and we're going to go over some data showing that. It's not just a test that works in Europe, so I think that's an important piece that's been missing for a while when making the case for stress CMR. It's non-inferior to invasive FFR, and we'll talk about that as well. And we'll talk about some ideas in terms of multimodality imaging and stepwise testing. And the benefits, again, there's no radiation, and potentially we could have a test with no contrast administration in the future as well. So before I get to the newer trials, I just wanted to cover one landmark study, just to point out that CMR really does outperform SPECT. The CMARC study, this is a huge trial for stress MRI in the sense that the gold standard was offered to everybody. So all patients had an angiogram, and they also all underwent both CMR and SPECT for their functional assessment. And what we can see is MRI really statistically significant improvement in sensitivity, negative predictive value. The area under the curve here for this ROC analysis, you can clearly see CMR really outperforms, and it outperforms SPECT both for single vessel assessment and multi-vessel disease, and also even changing the definition of what's severe over a wide range, basically, of definitions of what we think is significant disease by invasive angiography. MRI really outperforms SPECT. And part of the reason for that is it's simple. MRI just has better spatial resolution. So if we look This is a clinical example. You can clearly see that the patient has a subendocardial infarction in the infralateral distribution and also some at the apex. Really not able to resolve any of that with SPECT. And then on the right side, there's an animal model. So if we look, you can see that there's an an inferior and infraseptal infarction. And you can clearly see it on the histological slides as well. And with SPECT, again, the resolution isn't good enough to pick it up. So MRI in plane spatial resolution is anywhere from, it's like 1.5 to 2 millimeters, whereas SPECT is more in the range of 10 to 12 millimeters. Normal wall thickness is sort of 10 millimeters. So things that are smaller than that, you might not resolve very well with SPECT. So transmural infarction, I think with SPECT is fine, but more subtle abnormalities you might not see. And there's an interesting study just looking at silent MI that's sort of picked up by MRI, and those patients who have late gadolinium enhancement in that distribution have worse outcomes. So last point on this, I think the Achilles heel of functional testing is that you might miss coronary disease entirely. But at least with MRI, if there are old events, you can reliably pick them up. So now moving into modern studies, and I think this is what's going to make the case for stress MRI in the US, is the SPINS trial was a large retrospective multi-center trial. It's kind of the first of its kind for the US, included more than 2,000 patients with stable chest pain and a history of MI in 15% and PCI in 23%. So following these patients up for a median of 5 years, the goal of the study was to evaluate the prognostic value of MRI and to investigate the downstream costs. The downstream costs. Sorry, guys, hope you can see me. And what they found is patients who were ischemia negative and LGE negative, over the whole study follow-up, they really had a low annualized event rate of under 1%. And then conversely, if you look at the LGE positive ischemia positive group, they had a 4-fold higher rate for the primary outcome and a greater than 10-fold rate of revascularization within the first year. And you can see in blue on the right side of the screen, the ischemia negative group. Really throughout the study, the rates of revascularization are very low, just 1 to 3% essentially, and it remains low. And patients who ended up with revascularization, after most of it was accounted for within the first year, and then thereafter, relatively low rates. And of note, 339 patients, so 14% of the registry, were found to have MI by MRI, but they had no clinical history of MI. And so looking a little more closely, on the left, we have event-free survival stratified by ischemia and the presence of late gadolinium enhancement. And on the bottom, we have stratification by the severity of ischemia. And again, same finding with the blue line here. You can see that the event rate is low and significantly different from ischemia positive, LGE positive. The middle group, there wasn't a statistically significant difference. So patients who were either ischemia positive, LGE negative, or ischemia negative, LGE positive, they were kind of intermediate risk. And the same goes with no ischemia versus severe ischemia, and then moderate and mild ischemia were not significantly different. So importantly, on multivariate analysis, LGE and ischemia both were independent predictors. And then lastly, the costs of ischemia testing. So again, folks who were ischemia negative and LGE negative, over the whole 5-year period, pretty low costs. And those who were in the higher risk group, most of the cost incurred was within the first 90 days, and that was driven by invasive angiography. But then over the rest of the study follow-up period, most of the cost was driven by SPECT. And then next, looking at a sub-study, so this is examining patients with an LVEF of less than 50%. This was about 500 to 600 patients. There's a median follow-up of 5 years here. Again, we see the same thing. Despite the LV dysfunction, patients with no ischemia or late enhancement, they had an event rate of 1.1% for the primary outcome. And on univariate analysis, presence and extent of both ischemia and LGE were significantly associated with the primary outcome. And here again, you can see just in terms of stratifying, what's interesting is the highest risk groups, one is obviously LV dysfunction with ischemia, but those who had no ischemia, regardless of what the LVEF was, they were a lower risk group. So those with an EF of 40 to 50% with ischemia were still higher risk than those with reduced EF and no ischemia. So similar to the SPIN's main study too, there were low costs overall for this group with no ischemia, no LGE. And in this cohort, essentially the ischemic pattern for LGE was seen in 48% of folks, but a history of MI was only present in 24%. So again, something like SPECT would miss this. And even if we were thinking about echo, really if you're relying on regional wall motion and looking for changes with stress in the echo lab, it could be a non-specific finding. You could see regional wall motion abnormalities in non-ischemic cardiomyopathy. So it's not always as helpful. I think with MRI, there's not much of a debate with what you're looking at. And I think the largest, so SPINs, I think the real added value for this tremendous body of work is they provided the missing piece to the puzzle for the United States, and that is that stress MRI is cost effective. So they compared the incremental cost effectiveness of stress MRI as a first-line strategy against invasive angiography plus or minus FFR. They looked at SPECT, coronary CTA plus or minus CT FFR for intermediate lesions, and no imaging at all. And they used $100,000 per quality adjusted life year as the threshold of willingness to pay for help, which I think in the United States makes sense. Typically 2 to 3 times per capita income is a good number. So I think the 100,000 makes sense. A lot of older studies used the 50,000 number, and I think that sort of came from the olden days, like in the 70s, looking at patients who were going to go on dialysis and sort of looking at cost effectiveness in that setting. But I think 100,000 is appropriate for coronary disease in the US. And what they found is overall CMR is optimal. While no imaging obviously would have the lowest costs, it also had the lowest quality adjusted life years. And SPECT, CTA, and invasive angiography all had higher costs. And more importantly, CT and SPECT had fewer quality adjusted life years than a CMR-based approach in the US health system. More importantly, I think also kind of first of its kind for stress MR in the United States, they did this probabilistic sensitivity analysis. And what they found is CMR is cost effective in 84% of iterations, while no imaging was optimal in 16%. SPECT and CTA and an immediate invasive approach, those were optimal in 0% of iterations. So that's a bit striking. And if we lowered the threshold for the willingness to pay to 50,000, then no imaging actually does become the preferred strategy. But that, again, that's not really realistic today. And another important point to make is that invasive angiography as a first line would only be cost effective in the US if prevalence exceeded 60%. So again, the SPINS trial, just to review, I think it really puts stress CMR on the map for the United States. So now just looking at some newer trials too out of Europe, and I think things get really interesting here. So this is a Spanish registry. This is a large retrospective study of more than 6,000 patients with stable coronary disease. And they had a median follow-up of about 6 years. So looking at all-cause mortality with respect to ischemic burden, corrected for the presence of LGE, you can kind of see predictably as ischemic burden goes up, all-cause mortality goes up as well. And then even correcting or adjusting for age, sex, diabetes, smoking status, and LV function, ischemic burden is still relevant. And most important is looking at those who were non-revascularized versus revascularized. During the follow-up period for the study, there were 587 revascularization procedures. So they used a propensity-matched population, accounting for variables like hypertension, prior revascularization, the presence of late gadolinium enhancement. And what they found is that all-cause mortality, it really increased with the extent of ischemic burden in the non-revascularized patients, while the opposite was noted with revascularization. And as you can see here on the graph, really the optimal ischemic burden to intervene is greater than 5 segments. So they had to have a marked perfusion defect to really benefit from revascularization. If we think about this, 5 segments is roughly 30% of the LV myocardium. This is markedly different from prior studies from SPECT, where we saw a benefit to revascularization at around 12.5%. And ischemia trial also used, ischemia thresholds closer to 12.5%. So what's important here, I think, is we need to figure out modality-specific ischemic thresholds and knowing when to act. And we definitely don't have a solid answer to that yet for MRI. So looking at another study, this is before ischemia trial, this is from 2017. There's a large Swiss study. They looked at 1,000 patients with a median follow-up of 2.5 years. And what they found here is patients with no ischemia or less than 1.5 ischemic segments, so that's roughly 10% of the myocardium, were the same. So there's really no difference if you had mild ischemia or no ischemia. But their threshold, essentially, if patients had greater than 1.5 ischemic segments, it was a strong predictor of the primary endpoint. And SCAR and left ventricular ejection fraction to a lesser extent. So looking at multivariate analysis, we're really seeing that ischemic burden is really what's driving our predictive value. And even in subgroup analysis, ischemic burden is really what's important. So it's an interesting study because it's really making the case that ischemia is something that we need to be thinking about. And here you can just see the incremental value of ischemia in the chi-square analysis is quite profound. So again, just important that we think about ischemia, and stress MRI is a great tool. And then moving on, in terms of stress MRI and invasive FFR, which we could say is the gold standard for invasive assessment of ischemia, stress MRI has excellent sensitivity, specificity, positive predictive value, negative predictive value for identifying obstructive disease. So on the left, we have a small validation study of about 100 patients who had FFR in all major patent epicardial arteries. And this was compared with stress MRI. And you can really see the numbers are excellent. So using an FFR of less than 0.8 or less than 0.75, MRI really excels. So on the right side of the screen, we have a meta-analysis. And here, essentially finding the same thing. So comparing some of these non-invasive tests to FFR, MRI again has an excellent sensitivity, specificity. The area under the curve for RSC analysis is excellent, 0.95. Whereas if we look at SPECT, which is the most common gatekeeper right now to the cath lab, really not as good. So this does make the case that MRI would be a better gatekeeper. PET also does a reasonably good job, but it's much less available. And then more importantly, MR-Inform is another sort of landmark trial. This was a multi-center randomized trial looking at about just like under 1,000 patients with stable angina assigned to stress MRI versus invasive FFR. And revascularization was offered if at least 6% of the LV myocardium was ischemic. So that's roughly 2 or more neighboring segments, or if FFR was less than 0.8. And the primary outcome was a composite of death and non-fatal MI. So the stress MRI approach was found to be non-inferior to an FFR approach as an initial management. And the MRI group was associated with a lot less revascularization, so about 37.5% in the MRI group and 45% in the FFR group. Some weaknesses to this trial, there wasn't a medical management only group, and there probably was some bias in patients who went for invasive FFR because it's easier to convert that sort of diagnostic procedure into a therapeutic procedure versus if you start with a non-invasive test. But it still makes the case that MRI is offering excellent identification of functionally significant disease similar to FFR. And now just changing gears a little bit, looking at patients. So if we think back to that ischemia trial, the excluded patients, so people who maybe had recent ACS or known revascularization. What's interesting is there's an Italian study here from 2016 called Strategy. What they looked at was patients with known coronary disease, and they compared a coronary CTA approach with stress MRI. And unfortunately, they didn't include FFR CT here for intermediate lesions, which would have been helpful. But what they found is that stress MRI was associated with less downstream testing, less invasive angiography, and essentially lower costs, lower radiation. So FFR CT may change this. And the CT group probably had higher rates of invasive angiography and revascularization. And I think that's what drove a little bit the higher rate of MI, because these were procedural. But it's an interesting finding. So patients that have known disease, CT can be tough. If you have calcified lesions, it can be really difficult to tell what's obstructive and what's not. And in my limited experience with FFR CT, it can still be difficult. Sometimes heavily calcified lesions are challenging, but with MRI, that really wouldn't be a problem. So these types of studies, I think, would be really interesting to see in the US. So that kind of brings me to another interesting study. This is from the Netherlands, and the concept of maybe mixing different modalities to identify patients that would benefit from revascularization is appealing, especially if the gatekeeper test to functional testing is low risk. So something like coronary artery calcium scoring is low risk. There's minimal radiation, there's no contrast, and it's a very quick test. So their objective here was to assess if stress MRI after calcium scoring improved the diagnostic yield of invasive angiography in patients with stable chest pain, and also to establish an association between the degree of calcification and myocardial ischemia. So they had about 600 patients, and those who had a calcium score of 0 were excluded. And it's a fairly low risk group, as long as they're asymptomatic. Patients with the perfusion defect went on to invasive angiography, and they were followed for a year. And the outcome that they looked at was obstructive CAD, so greater than 50% lesion in at least one epicardial artery. Or if patients didn't go to the cath lab, they looked at MACE as well. So they found obstructive disease in 12%, and the sensitivity and specificity of MRI was excellent. So 91% sensitivity 99% essentially specificity, and excellent negative and positive predictive values as well. Those who had a coronary artery calcium score between 0.1 and 100 without typical symptoms, really only 3% of those patients had significant obstructive disease, whereas those who had calcium scores greater than 400, even with non-anginal pain or non-cardiac pain, obstructive disease was found in 16%. So it's an interesting study because stress MRI, it is an efficient gatekeeper to the cath lab. And then in patients who have a positive calcium score, we can probably do a little bit better. So those with scores under 100 essentially could be deferred from further testing. So if we look at this sort of algorithm here, really in this lower risk group, unless they really had typical symptoms or other concerning clinical findings, further testing could be deferred. Whereas those with the calcium score of 400, really regardless of what the sort of nature of the chest pain is, they should go on to functional testing. So I think this is interesting also thinking back to the SCAPA study that showed that 40% of us are walking around with silent coronary disease. So the prevalence of CAD is high, and we really should be striving to identify those who have it. The benefit of MRI, again, outside of just stress testing, is that we can find silent MI, and we have a lot of added value in terms of looking at cardiac function. So lastly, before we're not pressed for time, I just wanted to talk about some really exciting techniques in terms of stress MRI without contrast, I think, which is really exciting. And also, there's some interesting studies that have come out recently using strain measurements, post-vasodilator, and also using AI-assisted quantitative assessment of perfusion. So I'm gonna spend a little time on this just because I think it's very interesting and exciting. T1 mapping, we're starting to use a lot in cardiomyopathy, and it's a good tool to characterize the myocardium and identify disease early. Sort of similar to strain that we use in the echo lab. T1 mapping is highly sensitive to changes in myocardial water content. So it can detect changes in myocardial blood volume. So it's a great sort of surrogate for changes in blood volume. First pass perfusion, which is how we do stress MRI now, that's really just looking at changes in microvascular blood flow. But T1 mapping, changes sort of pre and post stress, those reflect a much more comprehensive view of the vasculature, because you're looking basically at myocardial blood volume in the total volume of the capacitance vessels. So you're looking at the micro and the macro circulation of the heart. So what they found is, in terms of so they looked at just normal, they had some normal volunteers. At rest, you can see, compared to stress, there is a significant difference in the T1 values that they get for the T1 mapping. And it's because there's an increase in myocardial blood volume with stress. And they found that this applied both at 1.5 Tesla and 3 Tesla magnets. They also looked at a few patients that had coronary disease, and they found that ischemic myocardium, really, there's no significant change in the myocardial blood volume. And that was the same finding in infarct as well. So this is pretty exciting stuff. You're really harnessing the unique ability of MRI to characterize tissue, and you're really, over time, you're just looking at dynamic changes in the water content of muscle. So it's a very interesting concept in terms of stress testing. One of the downsides is quality control on T1 mapping is pretty tough, especially as you get towards the apex where the myocardium really thins out and the blood pool and the myocardium, can be some partial volume effect, and it can be a little bit difficult to tell what's going on. So 12% of patients were excluded just due to poor image quality. So I think that is something that's going to have to be improved upon. And there are new techniques coming out. So there's sort of free breathing techniques. There's motion corrected techniques. So hopefully this is something that we see more of in the future. And even more exciting, there's an exercise version of this as well. So this is just published by a group last year. So if you take a look, you can see there's actually a MRI compatible sort of bicycle or pedaling station, I guess. And then kind of post-stress, the patient can go right back into the magnet. And when I was in fellowship, we actually did something sort of similar to this. We had a hydraulic treadmill next to the MRI magnet, and you could have patients kind of hop right off and get into the magnet. So these are exciting techniques because now we're talking about really offering a comprehensive assessment of the heart, and we don't have to give contrast, and we can still get our functional assessment. So I think these are really interesting sort of future directions. And let me skip over this in the interest of time. One other thing I want to talk about was so longitudinal strain as well. We can measure this. We don't have to measure it at the scanner. So this is something that we can just do like we do in the echo lab with speckle tracking. So we can measure strain immediately post vasodilator administration with stress MRI. And this group looked at 500 patients, and they took a 2-chamber view basically immediately after regadenoson was administered. And offline, they're able to measure longitudinal strain. And the concept is strain, the endocardium is very sensitive to changes in the transmural pressure gradient of blood flow. So after adjusting for ischemia, late enhancement, and clinical factors, they found that reduced strain remained an independent predictor of MACE. And it's a very simple Cine acquisition that adds really no time to the scan whatsoever. So if we think about now, we have a couple tools that are non-contrast if we were to add them together. So if we were to do T1 mapping, pre and post stress, and also look at longitudinal strain, I think there's a very interesting application of both of those techniques together in the future. So hopefully we see things like that. And then lastly, a lot of people are talking about AI, and I think this is an interesting study. So this looked at 1,000 patients, and really with no user input whatsoever, there's an AI algorithm that was able to measure myocardial blood flow and then also calculate myocardial perfusion reserve, which is just the ratio of stress over rest myocardial blood flow. And both were independent predictors of MACE. And I mean, essentially, sometimes stress MRI, it can be a little bit difficult to read. It's not always easy to see like a smaller subendocardial perfusion defect. So it's nice to have an AI assist and to be able to, comparable to PET, to be able to give this sort of myocardial blood flow and to give the perfusion reserve. So I think the future for stress MRI is really bright. I think there's a lot of interesting techniques that are coming in the pipeline. So in conclusion, I would say the paradigm for the initial evaluation of chest pain is dramatically changing. And I think really it's changing for the good, because CT really gives us the opportunity to rule out disease and send people home. And then also identify sort of mild disease where we can treat earlier. I think ischemia testing is definitely relevant, and I think stress MRI is underutilized. And I think better ischemia testing will lead to better trials and better data. And what's more important is with SPINS, we can see that within the US healthcare system, stress MRI is cost effective. And if we have clinicians who are really involved with the acquisition of images as well, there's a wealth of rapid protocols. And I honestly think you can get viability, stress, function, and even a look at the valves in about 30 minutes or so. So compared to other stress modalities, it's a marked improvement. And I think things to look for in the future is we hear more and more about inflammation, and there may be new therapeutics to treat coronary disease with anti-inflammatories. There's a lot of direct vessel imaging with MRI, even looking at the coronary arteries themselves and looking at T1 times within the vessel wall. I think the future is bright if there are new therapeutics in line and we need to look at the vessels. And I think that also applies to CT. I mean, we're able to do a lot with CT now with advanced plaque characterization, but over sort of just identifying coronary disease and looking at plaque volume, I'm not sure that we can do a lot with that clinically until there's a reason to. So with that, I'd like to have Leander take it over again for the Q&A.
Thanks, Vic. That was great. And we have Dr. Garcia joining us for the QA as well. That was an outstanding lecture. I love how you showed the different function of each imaging modality. And I think I agree with you. I think many times we focus on ECT going to take over everything, but not every patient is like CAD. We have so many patients with CAD that we need information, and CT clearly is not the best for those patients. So great data. I'll let Dr. Garcia start with the first question, and then we have some other questions as well.
You know, I have to second that, Vikram. This was an outstanding, very comprehensive, and very up-to-date presentation. I do agree with 99.9% of everything you say, and I think it's a very exciting tool that we need to use more often. One of the I guess the limitations of MRI, of course, when you compare with other functional imaging modalities to ischemia, of course, is that it's very difficult to exercise on an MRI. They have been investigators have tried that. Actually, you come from Ohio State, and Ohio State, Subarama at some point she was working on a biking protocol for MRI. But in most places, you're right. It's a pharmacologic stress that you do. On the other hand, the advantage is that you can choose to do a vasodilatory protocol with regadenoson, or you can choose a protocol with dobutamine, which offers you the flexibility, because there are some patients that do better with one versus the other. What is your experience on one versus the other, and how about using both?
Yeah, absolutely. I think so. I didn't touch on dobutamine stress at all, and there's excellent data for dobutamine stress MRI, and also even looking at viability over late gadolinium enhancement. We didn't do as much dobutamine stress where I was, and I think partially just, it's a little bit more resource intense in terms of having nursing and monitoring and having patients sort of in the scanner a little bit longer. But I think similar to echo, it really offers a lot of good information. And I think if there's more than single vessel disease, you can really pick it up. And real-time techniques, so real-time imaging techniques have gotten quite good. So the spatial resolution is great. And if the comparison is with the echo lab, we're still going to do a lot better with MRI. So I think it's a very interesting thing. And then I'm just seeing one question popped up about the pros and cons of MRI versus PET versus SPECT for viability. Which I think that's a great question. So my take on the benefit of MRI, I think it is the gold standard for viability. The reason being is that there's a clear anatomic correlate. So you can take a histological slide and actually look at the infarct and compare it to MRI. And you can't really do that with any other modality. And it's a direct visualization of infarct. So really, there's no better way to look, I would say.
I think devices probably, right, is one of the times with MRI. I mean, we're doing it with devices, but it just can become a little bit more challenging to fully evaluate that. And maybe you think, I mean, sometimes breath holds can be or a little bit harder with MRI versus PECT or SPECT.
I think that's true. I mean, I guess I think with devices, I definitely agree. But I think with the breath holding, because I feel like a lot of clinicians get turned off with MRI because they hear about, oh, the patient couldn't breath hold, or they went down for their scan and now they're back with the non-diagnostic study. I don't ever want to order it again. You know, you hear that a lot. So I think what I'd want to tell sort of people who don't do MRI, or just like the clinicians in general, there are a lot of ways around the breath holding issues. There's a lot of sort of free breathing techniques now. And even just using single shot imaging, which is similar to echo, like just looking at the heart in real time, I think we can still offer quite a bit. So I don't want people to get sort of disappointed with that.
I guess that comes, and having Dr. Garcia to here is also very to the point for this, for the his recent review on viability on circulation cardiovascular imaging that I invite everyone to read. I guess a question before that is viability dead, or we still should look at viability for both of you? Probably that question.
I think so. Yeah, I think viability would be a whole lecture unto its own. My personal view on viability is I talk to patients about it before I send them to a viability study, and you know, I agree. I don't think you can we really shouldn't be denying people revascularization based on viability, because I don't think we have good data to do that. But I think we can at least give them an expectation of what may or may not happen. Because I think even people who have non-viable segments and reduced EF, I mean, if, like, you know, just looking at the Stitch trial results that came out like a couple of years ago, I mean, patients still benefit. So there's something outside of just segment by segment viability. You know, revascularization offers something that improves the heart overall. So whether that's sort of peri-infarct zones and VT, pump function, you know, there's something else to it. So for me, for viability, I think it's interesting for CTO patients. I think there's some data that you can base your decision for CTO intervention on MRI viability. But I think it's a very controversial area. I don't know, what do you guys think?
So I recently was involved to comment in a case, and I want to illustrate one of the issues that I think has been a problem when you interpret some of these clinical trials, and also an error that we made very commonly. It was a patient who had some vague symptoms, some heart failure symptoms. I had a coronary angiogram that showed a very significant proximal lesion on a dominant right coronary artery, and the patient had an MRI done that showed a transmural scar at the base. Obviously, the MRI was read as no viability, and yet what wasn't taken into consideration were that the lesion that was in the coronary did not match the stent that was seen on the MRI. So when you look at these patients, you have to also add ischemia to the factor. And maybe one thing that we should be doing consistently, or maybe moving forward, is to do an stress MRI at the time that you're doing a viability assessment. Because if you have a scar and you have no ischemia, it's different than if you have a scar plus ischemia. And I think those patients are not being adequately characterized in many of these clinical trials. I do have a comment here from Dr. Herrera from Dominican Republic. Need to say that one of the groups that more consistently follows these presentations on Fridays is the Division of Cardiology from CEDIMAT. Which is an excellent institution led by Dr. Herrera. And he's basically mentioning his comment about the ischemia trial. Basically, he's saying he's not sure that ischemia answer the key question of which test modality to use. It may be what he shows is that it's, none was actually needed, more likely a clinical context. But MRI was not studying ischemia, and that's something to keep in mind.
I think we have a few comments and a question. It's a question about Wakefield campus. Hopefully very soon we'll have a cardiac CT available there. There's a work in progress. We can't say yet, but hopefully very soon you'll have more availability there. And a question from Dr. Travin. Any future utility for PET MRI together? There's only a few of these scanners, I think, in the country. Maybe not for ischemia, but perhaps for more comprehensive assessment of viability. What do you guys think?
I'll be honest, I'm not sure. I think with PET, I would say in terms of myocardial blood flow and ischemia evaluation, it's excellent. And it improves upon the spatial resolution of SPECT for sure, looking at viability. But with MRI, I think we're starting to get to a place where we can also do sort of perfusion reserve pretty well. And with some of these AI-assisted techniques coming out, I think I'm not sure. I don't envision a huge future of the two together. What do you guys think?
It's an interesting tool. It's a very sophisticated piece of equipment, very expensive, very exclusive. And the question is whether there's any data that have shown that doing the two studies separately on two separate machines is different than doing it combined and one single sitting in one machine. For oncology, where you need precise localization for tumors, the small tumors, it makes a lot of sense. I think I haven't seen personally any data for cardiac indication.
I think cardiac sarcoidosis, right, is one that could be potential great use for that. But yeah, there's a lot of more data that needs to come on viability for that. There's no more questions. So thank you very much, Vic. That was an outstanding lecture, and Dr. Garcia for joining us. And I'll see you guys soon. Next week, we have a lecture about cardiac sarcoidosis. So we'll be talking more about the PET MRI.